number one, understand the difference in the role of the liver and the kidney in drug elimination. And then just sort of list all the routes by which drugs can be eliminated and explain why we talk about kidney specifically. Next, we will talk a little bit about kidney structure and function, as much as you may need to understand this particular topic. So we won't go in depth of kidney function. Can you hear me well, since I don't have a mic or anything? Everybody back there? All right. Please, if I'm not loud enough as the lecture goes on and you can't hear me, let me know. Then we will talk a little bit about properties of urine as they influence drug elimination, and finally we will see how aging and kidney disease alter drug elimination. So let's start with defining what drug elimination is. So it's the irreversible loss of the drug from the body. And there are two processes that make up elimination. Metabolism, which refers to conversion of one chemical entity to another, and the purpose of which usually is either to detoxify, or when we talk about elimination, to turn drug into a metabolite that can be easily excreted through either a route that we will be talking about. The second process, of course, is excretion, which is loss of chemically unchanged drug. So most of the change occurs through metabolism, and most of it in the liver, and then excretion is just loss of the drug from the body. And you are already familiar with this absorption, distribution, metabolism, and excretion diagram. The part of it that we will focus on today is this one. Okay, biotransformation, metabolites, which facilitate excretion. So again, elimination comprises these two processes, excretion and metabolism. And most of metabolism occurs in the liver. So metabolism, making what liver does for the most part is making metabolites that are soluble in water. What is soluble in water gets into plasma, what gets into plasma gets easily to the kidney and can be excreted. Now, loss of chemically unchanged drug, the excretion part is the kidney. So the amount of drug eliminated is the amount transformed in the liver plus the amount excreted by the kidney. So the clearance, additivity of organ clearances, so the clearance of the drug from the body is comprised of the clearance that pertains to liver and actual renal clearance. So hepatic and renal clearance. So what are all the routes by which drugs can be eliminated? Here we go. Here's the metabolism, and here's the excretion. So there is a whole long list. Why, when the list is so long, do we concentrate on the kidney? I mean, drugs can be excreted in the bile, feces, rat, milk, tear, saliva, expired yeast. Yes?
Well, you said everything had to be water soluble, right? So, or all the metabolites, so that's the easiest way to get out of something that's water soluble.
Okay, so one answer is because liver takes care of many metabolites to become water soluble. Because they are water soluble, they can be excreted by the kidney. What's another reason? So why do we focus on the kidney in particular? Why not the tears? Or really?
Most of it's excreted that way?
Exactly. So that's the quantitative aspect. yes, a little bit of drug gets to all these different fluids. And that may be important, let's say, if you're thinking about the drug being causing an allergic reaction. Okay, well then interfering with all these other fluids is important. Milk, obviously, can, a drug itself or a metabolite can be toxic to the infant. But quantitatively, most of the elimination and that is excretion goes through the kidneys. That's why we concentrate on the kidneys, the quantitative aspect. It's by far the most important one. And so how does the kidney work? So this is nephron. It's the physiological functional unit of the kidney. And it's essentially comprised of two main parts, of the glomerulus, right here, and of a tubular system. So glomerulus plus tubules comprises the nephron. The glomerulus, this is a scanning electron micrograph. So glomerulus is essentially a bundle of capillaries. But it's a peculiar bundle, like no other in the body, because this is the afferent arteriole that brings the blood to this bundle, to glomerulus, and this is the afferent arteriole. So what's unusual is that an arteriole brings blood to a capillary bed, but then instead of venule, it's the capillary, another capillary that leaves the bundle. So that's the only place in the body where you have a capillary bed, and I call it a little bundle of capillaries because it's round in shape, where you have two arterioles supplying this capillary bed. What that allows us is to control the hydrostatic pressure. So glomerulus sits between the two capillaries, and the hydrostatic pressure can be regulated by the tonus of these two. And kidney has a very sophisticated system that you perhaps heard about, renin-angiotensin system, to regulate the tonus of these capillaries. And by doing so, it actually regulates the hydrostatic pressure in the glomerulus. So that's first peculiar thing about the kidney. That also means that this capillary bed can achieve much higher hydrostatic pressures than elsewhere in the body. Now the tubular system is long, sophisticated, and interesting, and the one that I always have found, I have always been curious about, because it's, you see, these are those cylindrical structures that are layered by a single layer of epithelial cells. So what's filtered in the glomerulus flows through the tubular system. And it is those epithelial cells that layer the tubules that decides what stays in the tubular system, which eventually gets to the urine, and what gets reabsorbed back to blood. In a very simplistic terms, and the simple way to think about the function of the kidney is this. So blood flows through the glomerulus, right here, and everything, all the aqueous phase of the blood gets filtered. So everything but cells and proteins. And then the ultrafiltrate flows through the tubular system. These cells either leave substances in the tubule or reabsorb it back to blood. So the way we work is we filter blood all the time, we reabsorb what we need, and we leave in the urine what we don't need, okay? And there is a small percentage of substances which are secreted, and drugs are among this small percentage. So these little cells actually decide what goes back to blood and what stays in the urine. That's how urine is formed. So everything is filtered, everything is reabsorbed, except for what we don't need. Okay, now this tubular system has a very tight and interesting relationship with blood vessels. So this is the nephron as I've shown you, glomerulus and the tubular system. If you look at it here, we are now trying to relate the nephron with the capillary bed, with the vascular part. Okay, so here's the glomerulus that we just spoke about, a bundle of capillary. This is the afferent arteriole. So this is where blood comes into the glomerulus, into the kidney, and it leaves through the afferent arteriole. What is filtered here in the glomerulus goes through the tubular system, okay? And what leaves the glomerulus through the afferent arteriole then goes through the peritubular capillary. And the peritubular capillary is next to the tubule. So here the filtration occurs, here the reabsorption occurs. Let's look at this bigger one, which has our kidney ABCs. So A is glomerular filtration. So in order for something to be excreted in the urine, it has first to be filtered. So that's the element number one. Filtration, glomerular filtration. And it occurs in the glomerulus. What gets into the tubular system, for the most part, it gets reabsorbed. So quantitatively, if you look at the transport in the tubules, the highest transport is the reabsorption. So our A is amount filtered. Our B is amount reabsorbed. That goes back into the peritubular capillary. And then there is, as I said, a smaller, quantitatively smaller amount that's secreted. So that's taken up from the peritubular capillary into the tubule. And I will explain momentarily how that's done. So this ABC, in this ABC, the amount excreted is amount filtered minus amount reabsorbed, because that goes back into the peritubular capillary, plus amount secreted. And each substance, either endogenous or exogenous, has some combination of these ABCs, okay? What is really important for this class, for pharmacology, is the amount secreted. Because many drugs, many toxins, xenobiotics, environmental toxins, heavy metals, and so on, are actually secreted. Any questions here? Is this, are you with me? Yes?
So X does not equal C.
I'm sorry?
X is not equal to C.
X can be close to C, provided that these two are very small. So essentially, every substance is ABC. It just, the quantitatively, A and B can be small, and C can be big, or maybe A can be big, and B small, and C big. It's different combinations. We will go over it.
I think she's asking what the difference is between the amount secreted and the amount excreted. Is that what you're asking? What the difference is there?
Amount excreted, so it's the sum. So amount excreted is ABC, it's the sum. So we start with the amount filtered minus amount that's reabsorbed plus the amount that's secreted. So usually we have all three components. If these first two components are relatively small, that amount excreted would be similar to amount excreted to amount secreted. And when I say most of the drugs are secreted, that means that that component, these three, for most drugs, is the most important one. Have I answered your question? Okay. Thanks, Steve. All right, so the polarized epithelial cells. Oh, well, can you give us Is there, this one takes the whole, white is red.
See what happens.
Okay, activates an alarm or something? Oh, well. Why would you put that in red? These are tubules. These sort of greenish shadows that you can see here. It's a cross section through a kidney tissue slice, and a cross section through a tube. So this is the lumen of the tubule, and in this tubule, which happens to be collecting duct, so this tubular system has different parts of the nephron with different functions. And so here we labeled the cells that in one layer lay the tubule. So as you can tell, it's a heterogeneous cell population because not all the cells labeled. But the reason I'm showing you these cells, which by the way secrete acid, is that the polarized epithelial cells have different apical and basolateral membrane. We use the specific transporters to label these membranes. So in the cells that secrete acid, the proton ATPase is located on the apical lumen of the cell. So this is the tubule lumen. This is the apical membrane of the cell. And so that's where the proton pump is that secretes acid. On the basolateral side is a chloride bicarbonate exchanger, certain AE1. So the cells secretes acid, secretes proton on one side, and reabsorbs bicarbonate on another. Bicarbonate and proton make carbonic acid, which dissociates in water and CO2. And so this cell, by recycling this reaction, can secrete protons and reabsorb bicarbonate and have net acid secretion, but maintain neutral intracellular pH, about 7.2, 7.3. So that's how, in principle, kidney cells maintain their own environment while secreting certain substances in the urine or reabsorbing them by this polarized arrangement of the transport molecules. So that's the key to the formation of urine. We filter everything. That is totally unselected process. It's these cells that are selected and the transporters which are arranged either apically or basolaterally. And the curious thing about this particular transporter, if you have a mutation in it, people get sick. They can't excrete, so just a single amino acid or 10 amino acid mutation in this causes renal tuberculosis. People can't excrete acid. Or for the other transporter, which has to be on the basolateral side, so this cell can secrete acid in the urine and reabsorb bicarbonate, which is base in the blood. If that transporter has a mutation, it migrates, it either stays in the middle of the cells or migrates to the wrong membrane, and again causes actual clinical phenotype. So this specific arrangement of these cells is of paramount importance. That's what decides whether something is reabsorbed or secreted. The cells that are arranged in this way will secrete acid. There are others next to them which are arranged in exactly opposite way. They secrete bicarbonate to the apical side and reabsorb acid in the blood. These cells actually secrete bicarbonate. So the direction of the transport and ultimately the composition of the urine is decided by the polarized arrangement of these proteins. And if that arrangement is not correct, then clinical phenotypes may arise. So that's the polarized renal epithelial cell. All right. And this is where it sits. Okay, so that's the little entity that decides about B and C. It's the glomerulus that decides about A, the amount filtered. It's these polarized epithelial cells that line kidney tubules that decide about B and C, which is what gets reabsorbed and what gets secreted. And if you, here's another picture. So what we have just looked a minute ago was a cross-section on which the tubule, it was cross-section like this, so the tubule was labeled. All right, so these were tubules. But these tubules and these polarized cells are sitting next to the peritubular capillary. And to illustrate that, look at this photo. Okay, so here's the tubule, and here are around it the peritubular capillaries. So it's this juxtaposition of the tubules and the peritubular capillaries that allows these cells. So this is where those colorful, beautiful green and red cells sit, and they communicate with the peritubular capillary really tightly. Now, do you have any questions here regarding this arrangement? Okay. You can, if you during the lecture remember something or it comes not quite clear, just feel free to raise your hand anytime. Okay. So now let's go to the amount filtered. Let's go back to glomerulus and see how what happens there. So there are two properties of the glomerulus that allow this fast filtration, this enormous filtration rate. Okay. Let's cover that up. One is this arrangement with the two capillaries that come to the glomerulus, afferent and efferent arteriole. So this capillary bed sits at the in between of two high resistance vessels and has high hydrostatic pressure. Hydrostatic pressure drives filtration. Another property of these capillaries that allows for enormous amount of filtration to occur is the permeability of these capillaries, which is different than anywhere in the body and is bigger. So the membrane, the one that actually separates the aqueous part of blood from the ultrafiltrate, that is proteins and cells on one side and everything else on the other, is this glomerular filtration barrier. And if you look at this electron micrograph, you can see, so this is the blood side, this is the urinary space, okay? And this barrier is formed of the endothelial cell. So this is the part of the endothelial cell, and the endothelial cell has this this quote-unquote processes which have so-called fenestrae. So the capillaries in the kidney are fenestrated. Fenestra means window. So they have these big gaps between the plasma membrane. So that's one element that allows for the fast perfusion. Then in the middle, there's a glomerular basement membrane. And on the other side, there are podocytes. And what you can see here are just parts of podocytes. So podocytes are a very specialized type of epithelial cell that you can think of. These podocytes feed these processes. You can almost think as a retainer. They have these little pores that sit on the basement membrane, and between them have these little slits. That's a slit diaphragm between the podocyte food processes, and they keep that membrane intact. And for the most part, they maintain its structural and functional integrity. It's these very specialized and differentiated epithelial cells called podocytes that secrete different proteins which sit over here on the slit membrane that then maintain the intact the whole basement membrane. And most of the genetic disorders and glomerulopathies actually are mutations which occur in the genes that code for the proteins that make up this this glomerular filtration membrane. So 3 elements: endothelial cells, glomerular basement membrane, and the food processes of the podocytes. That's what makes up for glomerular filtration barrier. To be to allow high flux of the fluid, but also to be selective. So its size is between 2 and 4 nanometers. Nanometers, remember, it's 1 times 10 to 9 meter. Okay, 10 to 9. So 2 to 4 nanometers. That's right at the edge where the albumin is. Albumin is the most abundant serum protein, is just about that size, but it's negatively charged, and the whole membrane is negatively charged. So that's the cutoff. So when I say we filter everything but cells and proteins, yes, most of the proteins are retained in the blood space, but you know, few may seep through because this membrane is they are just at the cutoff. And of course, peptides, which are smaller than albumin, can freely go into the urine. So that means in urine you can detect different peptide hormones and you know, peptides of various sizes. Okay, let me show you what the podocytes look like. So what I will show you is a confocal. It's a video from a confocal so-called Z-stack. So what the fluorescent confocal microscope does, it scans the X and Y axis of whatever you label with something that you label with a fluorescent dye. And what you can do is you can make it so you can make the microscope do the scan in so-called optical sections. So you can put those optical sections very, very close by. So it scans one plane and then scans another and so on and so forth. And if you go through the whole glomerulus, you have the so-called Z-stack, and you can reconstruct the structures that are fluorescently labeled and contained within the glomerulus. So I want to show you what the podocytes look like. If I can get moving, going. They are labeled here in green. Let me run this for you again. So if you look very carefully, it's a little fast, and in this program I have no way to slow down the video. But you can see the cell bodies and all those processes. So podocyte is a very peculiar cell that has this epithelial cell body, but then has processes on all sides. These processes are those retainers, the food processes, the retainers that sit on the basement membrane. So I'm showing you those cells just so that you have a better understanding of the complexity of the glomerular structure. You don't have to remember them, and I won't ask about the types of glomerular cells on the exams, because people have been concerned about that before. Okay, so those are the cells that form those little processes here. And these are endothelial cells. I'm going to, again, endothelial cells here are labeled in green. So I'm going to run this a couple of times and see whether you can see the shades of the blood vessel as the microscope goes through these optical sections. Okay, here. You can see the luminol of the little capillaries. So that's this is the part, and I'm just showing you that's the part, the endothelial cells. Okay, so they are from on the other side of the glomerular basement membrane. All right, and finally, although not a part of this particular barrier, there are cells which are essentially modulated fibroblasts and muscle cells, which are called mesangial cells, and they provide the stroma. They actually keep the glomerulus intact and give it its shape. And in the diseases, they start secreting a lot of matrix. So that's not a good thing, to have a lot of matrix, extracellular matrix in the glomerulus. So those are the mesangial cells that sit in between and provide the structural support for the glomerulus. Now, so 3 cell types, essentially. Endothelial cells. So this is the schematic of what we have just looked at. Endothelial cell on the blood side, the basement membrane, and on the other side is the podocytes. And you've seen they have bodies and they have those elaborate processes. And these little pores are what really keeps all this intact. And I have put in our folder for the lecture this paper, so you can look at it if you want, for the nerds in the audience. I have a couple of things for the nerds who want to go into these things in more detail. All right, so how does the filtration occur, and what are the forces that actually drive filtration? The same as in any capillary. There is difference in the quantity, but the forces are actually the same, and they are like the classic Starling hypothesis. So glomerular filtration rate consists, this K is the permeability coefficient. So what goes into this permeability coefficient and what makes it different than elsewhere in the body are these fenestrae of the endothelial cells, special properties of the basement membrane, and the little foot processes. So the 3 of them make this permeability coefficient unique and high. And then there are hydrostatic and oncotic pressures. Oncotic pressure refers to pressure exerted by proteins. So if you look from the blood side, what takes ultrafiltrate outside of the vessel is the hydrostatic pressure. And hydrostatic pressure in normal capillaries is about 10 to 20 millimeters of mercury. In the glomerulus, it's 50 to 60 millimeters of mercury, owing to these 2 capillaries that are at the beginning and at the end of the glomerulus. So it's a relatively high hydrostatic pressure. So that's what drives the blood out of the vessel. What helps that is, so this is the blood side, this is the urinary side. And I said for the most part we do not filter proteins because of the properties of the glomerular filtration membrane. But a few proteins do seep through. And so there is a very small amount of proteins on the other urine side. These proteins on the urinary side, in the ultrafiltrate, they exert small oncotic pressure. So what drives filtration are 2 things right here. That's the hydrostatic pressure in the glomerular filtration capillary and the small oncotic pressure in the urinary space. The few proteins that sit through the barrier. These, because the oncotic pressure is going to drive the ultrafiltrate this way, and the same thing with the hydrostatic pressure here. What opposes the filtration is hydrostatic pressure that builds up in the tubule. So here's your glomerulus, and unlike like anywhere else in the body. Ultrafiltrate from these capillaries enters the tubular system, so it doesn't go into the extracellular space like elsewhere, goes into the tubular system. But here, right here, that's so-called Bowman space, and this is tubular space. So here, as the blood is filtered, the ultrafiltrate builds up a relatively small but significant hydrostatic pressure. Now that pressure that builds up here opposes filtration, obviously. Okay, so the glomerular filtration rate consists of the glomerular filtration is facilitated by the hydrostatic pressure in the capillaries and the oncotic pressure in the urinary space. Hydrostatic pressure here, oncotic pressure here. It's opposed, so minus, hydrostatic pressure in the tubule, and of course, the oncotic pressure of the proteins. So as the fluid leaves the capillaries in the glomerulus, what's left? The cells and the proteins. These proteins that are left in the glomerular capillaries, once the fluid leaves the capillaries, they will exert substantial oncotic pressure and will impede filtration. So it's really relatively simple. Yes?
I'm a little confused. The oncotic pressure is the pressure of the proteins.
Yes.
Correct? So you're saying that the oncotic pressure is going to be seen in the tubule, like the proximal tubule?
And in the capillary. So the proteins, most of the proteins are in the blood. And when the ultrafiltrate leaves the capillary, so the question, let me repeat the question. So the question is, where are the oncotic pressures that contribute to glomerular filtration? So which proteins, where, and which pressure, is that right?
Yeah, kind of, because there should be proteins in the tubule, correct?
Yes. So most of the proteins are in the capillary, so in the blood space. Ultrafiltrate leaves the capillary and proteins stay there, so that's where the concentration, as the glomerular filtration goes on and on, the concentration, if you will, of proteins in the capillary increases. So the oncotic pressure increases. That's the pressure that will impede the glomerular filtration rate. Now, most of the proteins will stay in the capillaries. There will be just a few that will seep to the urinary space. These that seep to the urinary space will exert relatively small oncotic pressure in the urinary space. What happens with those few pure proteins that have gotten into the tubular system, most of them are reabsorbed by the endocytosis in the proximal tubule. So no protein in the urine. That's why protein in the urine is a disease. You don't want any protein in the urine. Yes?
Right, so a question on that. So say when a patient has large amounts of protein in the urine, is that indicative of an insult to this membrane or a pressure imbalance, either or both?
Excellent question. So if a patient has a lot of protein in the urine, what is the cause? Imbalance in the pressure or defect in the membrane. So the cause number one is defect in the membrane. The pressure rarely affects occurrence of proteins in the urine because kidney has autoregulatory renin-angiotensin system. So kidney is very, very particular about sensing the pressure in the glomerulus at all times and adjusting it fine. So if it decreases, so that's why if the blood pressure increases, the perfusion pressure in the kidney in normal circumstances, in physiological, it's not going to change. So your pressure goes up, let's say you exercise, your pressure goes up, but your perfusion in the kidney stays stable. Or for whatever reason, your pressure goes down, your perfusion stays stable. So that's a physiological adaptation, so you can have your glomerular filtration going no matter what. So that's the purpose of that autoregulation. That's why the change in hydrostatic pressure is rarely reason for proteins in the urine. The most common reason is the one I've just mentioned. These food processes, these little retainers, either genes are mutated in them, and so the proteins that make up the membrane are not fully formed or are missing, or something happens, there's an insult to the podocyte, and that changes their morphology. So the pathologists, when they look at a kidney biopsy of a patient who has a lot of protein in the urine, the first thing they will look at is those food processes, the thickness of the basement membrane, because those are the two main elements.
Is that
Yes.
seen through like ultrasound then, or?
Well, ultrasounds you usually see, let's say, you will look for cysts or kidney stones, but how the glomerular filtration membrane looks, you have to do an electron microscopy. So you do that off of the biopsy.
Gotcha.
Yeah.
And that's probably
Yeah.
been a rare thing. You're more looking just at urine protein
It's-
concentration first before anything else.
Yes, oh, absolutely. You don't perform kidney biopsies unless you absolutely have to. Yeah, yeah.
Thank you.
Sure. So the question was, how do we look at whether the filtration membrane is intact? We look at it from the biopsy with electron microscopy. So clinically, the two things that we use to see the kidney function is glomerular filtration rate, for the obvious reason. Something has to get infiltrated to be excreted, and the other thing is urine. We look, protein. We look at the protein in the urine. So albumin, creatinine ratio, so UACR. So those two things. And now you know very well why no protein in the urine. Okay, other questions here? Okay, so this is, yes.
You said that most of the excess proteins are endocytosed. Is that what you said?
Yes,
Okay.
in the proximal tubule. That's why if the proteinuria is very, very low, it's so-called minimal proteinuria or microproteinuria, it usually comes actually from the tubule. There's something wrong with the tubule, so it doesn't endocytose these few pure proteins that seep through the membrane. Okay, so just to reiterate, the forces that drive filtration are really very simple. It's the hydrostatic pressure in the capillaries, which is highly controlled in the kidney, and the oncotic pressure of the proteins, mainly in the blood vessels and to a smaller extent in the tubules. And that gets us to the concept of clearance. So the concept of clearance goes like this. So kidney excretes certain substances, meaning it clears the plasma of certain substances. When I first heard this, it was so confusing because we are talking about the substance, but what's cleared is actually plasma. So that's why it has units that it does. So clearance is the volume. So it's clearance of a substance. Let's say clearance of creatinine, clearance of a drug. That's not that particular drug or let's say creatinine. It's the volume of plasma that's cleared of the substance Z per unit of time. And it's calculated by dividing the concentration. So the concentration of the substance in the urine divided by the concentration in plasma times urine flow rate. And because the concentration in urine, concentration in plasma, those are the same units, milligrams per milliliter, so that cancels each other. So that's how you are left with milliliters per minute. Although these milliliters per minute in this equation, they come from urine flow rate, in the concept of clearance, they actually refer to the volume of plasma in milliliters cleared of substance Z per unit of time, and unit of time is minute. So why would such a counterintuitive concept be useful clinically? It's useful because we can measure all this very simply. So it's easy to determine the concentration of a substance in blood. It's easy to measure it in the urine, and all you have to do for determining urinary flow rate is just to collect urine over a certain period of time, and there you go. It's your milliliters per minute. So it's very easy to calculate. And if you have a substance that is only filtered and is not either reabsorbed or secreted, then the clearance of such substance is equal to glomerular filtration rate. And such substance is inulin. I think it's isolated from Jerusalem artichokes, which I love. So inulin is just a substance that, for whatever reason, is only filtered, it's not reabsorbed, it's not secreted. So if you look how much of the plasma is cleared from inulin in a unit of time, you actually have glomerular filtration rate, because that's the only way it's excreted by the kidney. If you remember the ABCs, so the glomerular filtration, so the amount filtered minus the amount reabsorbed plus the amount secreted. So in this case, in the case of inulin, it's only the amount filtered. Everything else is zero. So that's why inulin, the clearance of inulin, is the clinical gold standard for measuring kidney function. Of course, you can't have everybody, collecting their urine for 8 hours or 24 hours all the time. It's impractical in clinic. So the closest thing that gets us to glomerular filtration rate clinically is clearance of creatinine. Now, creatinine is not quite as ideal because we do secrete a little bit of creatinine. So it's filtered and a little bit of secreted, but for the most practical purposes, it's okay. So we compare clearance of creatinine to glomerular filtration rate. That's why when you talk about kidney function, you talk about the level of creatinine. And now most of the labs have equations, so you have the certain MDRD, EPI, and so on. There are a couple of equations which take into account gender, race, and BMI in calculating the glomerular filtration rate. Okay, so you get the creatinine, serum creatinine, and you usually get also the estimated glomerular filtration rate, which is far from ideal. We need the better markers. If anybody wants to talk about markers of kidney function, I'd be more than happy to. Let me reiterate this one more time. So clearance is volume of plasma completely cleared of substance Z per unit of time. And as I said, it's very easy to measure. So concentration in the urine, concentration in the plasma times urine flow. Okay? What's it useful for? It tells us how the kidney handles a substance. For example, we just spoke at long length about inulin or creatinine, which is mostly filtered. So when we do the clearance of inulin, we actually find out that it's 120 mLs per minute, which is equal to glomerular filtration rate. So the filtration rate that we spoke so much about, it's 100 to 120 mLs per minute. That comes to 180 liters a day, 45 gallons. I wonder if we had 45 gallons, if we line them up here, probably the length of the room wouldn't be enough. So it's a huge, enormous amount. Most of that we reabsorb. That's why I'm emphasizing over and over again, the flux of filtration and reabsorption is huge. The secretion is relatively small part. And just technically, I mean for research purposes and for clinical purposes, it's not easy to measure because you have to separate this little secretion flux from this huge reabsorptive flux. Okay, so that's inulin. That's our aim. You have a substance like glucose, which its clearance is zero. Okay? Why? Because we reabsorb, unless we have diabetes, we reabsorb all the glucose that gets into filtrate because we need it. We don't want to waste it. Obviously, tubules have their capacity maximum, so they can reabsorb just so much glucose. If the blood sugar is so high to overcome this reabsorptive capacity of the tubule, the so-called tubule transport maximum, then glucose appears in the urine, and then you get the diabetes. So that's why it's such a paramount sign of diabetes. So that's for the substances that are totally reabsorbed. And then, and by the way, the latest anti-diabetic drugs are the ones that interfere with this reabsorption, change the absorption in the proximal tubule, and they work very well. So they inhibit that reabsorption. You get a lot of glucose in the urine, so you get rid of glucose in a very different way compared to other anti-diabetic drugs. And finally, you have something that resembles many, many drugs. That's para-aminohippurate, which is little of it is filtered and a lot of it is secreted. So in addition to what is filtered, there is the secreted part, which is huge. And para-aminohippurate is often used as an example of a secreted substance because if you actually measure it, its clearance is very, very close to actual maximum, which is renal blood flow. Why is renal blood flow the one that is the limit for para-aminohippurate secretion? It's because blood has to flow here so that you can extract para-aminohippurate into the urine. Again, that's 700 mLs per minute. So the only way to exceed the clearance exceeds the glomerular filtration rate is by secretion. If clearance is much lower than the clearance of creatinine or inulin, that means this substance is supposed to be reabsorbed. If it is much higher, that means it is, for the most part, secreted. Any questions here? Yes?
That's supposed to be insulin, or is that meant to be
Inulin.
Okay.
Inulin. Okay, so insulin is hormone that acts in the pancreas. Inulin is just the inert substance that we do not secrete or reabsorb, only filter. If one doesn't have enough insulin, then glucose appears in the urine. Okay, so that's not one. And often the drug elimination is expressed as clearance. So clearance, renal clearance of a drug it's the same formula. It's a concentration in the urine or concentration in plasma times urinary flow rate. And it varies from the negligible value, like for glucose, up to the theoretical maximum limit set by renal blood flow. Well, this should really be plasma flow. Blood flow is moving. The plasma flow is about 600 to 700 milliliters. Blood flow is bigger because you have hematocrit, you have the cells. So it's about liter or liter and 100. Let's go through this, not for the sake of numbers, but just as I would ask everybody when you look through the lecture, do this calculation again, just so you're sure you know where every component comes from. Let's say you have 0.1 milligram per ml of PAH in the plasma. the renal plasma flow is about 600 to 700 mLs. So 0.1 times 700 gives you 70 milligrams per minute. So that's how much is going to come through the afferent arteriole into the glomerulus. The filtration is usually 0.2, 0.1 of the flow. So let's say for the sake of simplicity, let's say glomerular filtration rate is 100 mLs per minute. Okay, so the filtered load of a substance will be its plasma concentration, 0.1, times glomerular filtration rate, here for simplicity is 100. So about 10 milligrams of the 70 milligrams that are coming through the afferent arteriole ends up in the tubular space. All the rest, which leaves the glomerulus to the paratubular capillary, comes from secretion. Now, one special property of the paratubular capillary in all these forces that we discussed is this. So the hydrostatic pressure is very high here, but since here is a high resistant arteriole that builds up pressure here, the pressure in the paratubular capillary is actually low. So in the glomerulus the pressure is high because we want to facilitate the filtration. In the paratubular capillary, which comes after this high resistant vessel, the paratubular the pressure is relatively low, so it's lower than in other capillaries. What does it help? It helps the reabsorption. Okay, and it also helps the secretion because there is not much hydrostatic pressure to opposite here. So 10 milligrams from here appear in the tubule. 60 milligrams are added by secretion, which makes for 70 milligrams per minute excretion. And if you just divide that with the urinary concentration of paraiminohippurate and times urine volume flow gives you 70 milligrams per minute. And if you just divide that with the concentration of paraaminohippurate, you get its clearance. So this is actually very close to actual measurement, but we simplified few numbers just to make it clear how high the clearance of a secreted substance can get. And that's the case for most drugs. Most drugs are secreted. Now, how does that happen? This is how. So going back to this smart little epithelial cells, and although nephron has different parts, most of the secretion occurs in the proximal tubule. And again, this is the tubular space. So this is the luminal apical membrane. So this is urine, this is blood. And there is this very sophisticated and parallelly organized sets of transporters that facilitate secretion. We will talk about transport and types of transport in a separate lecture, but just very briefly, so it is sodium, potassium, ATPase, which sets the electrochemical gradient for these transport. Sodium, potassium, and ATPase uses ATP. So this whole secretion thing is a very taxing process for the cell. It uses a lot of energy because it essentially, quote unquote, extracts the substance from the blood and then secretes it in the urine. And for doing so, it uses ATP. It starts with the gradients set up with the sodium, potassium, and ATPase, which then are used in those parallelly organized transporters on the basolateral side. In this case, let's say OAT1 exchanges alpha-ketoglutarate for PAH and takes it into the cell. It concentrates, so this transporter concentrates PAH in the cell, and then as the concentration of PAH increases in the cell, that facilitates either its facilitated diffusion or its exchange for other ions. So this is electroneutral transporter. There are many isoforms of these OATs. There's another paper in the folder for the nerds who want to look at it. But the point being is you have one set here and you have a different set on the apical membrane. So it goes from the basolateral, builds up in the cell, and then is excreted through the apical membrane. Now, here is why so many drugs are toxic to the kidney. Because in order for this to proceed, you have to build up the concentration gradient in the cell. When you build up the concentration gradient in the cell, that means that that poor cell is gonna face much higher concentration of that drug than anywhere else in the body. That's why kidney has problems with many drugs. And if you're developing a drug, your nightmare was gonna keep you awake at night is the kidney. So transport proteins that mediate secretion of organic onions and the kidney proximal tubule. This is just one example, the so-called OATs, and you have those that transport cations or anions or cations. As you can tell, it's very many of them. So now, one important thing here is that secretion. If you have a substance, so far we have been talking about the substances that are soluble in water. Well, so if something's bound to protein, then what? Proteins are not filtered. So almost the only way to excrete something that's bound to protein is secretion. How does that happen? So these guys have high affinity for those different substances, and their affinities differ. So some of the substances will be preferentially taken by OAT1 or OAT2 and so on and so forth. In the literature review, I've asked Kyla to present one paper that actually compares the diuretics, which are the drugs that inhibit sodium transport in the kidney and by doing so decrease blood pressure. So how are they taken up by these different transporters? So these transporters have different affinities for the substance that they want to secrete. And let's say this is the pool of the drug that's bound to the protein. That cannot be excreted because protein does not filter in the kidney. But that's in balance, where the small amount of the free, yes?
I'm sorry,
free
can you use
drug.
a different marker? I'm having a really hard time seeing.
Oh, okay, yes, well, I'd love to, if there were one. Let's use this paper, probably it's there. Okay, so let's say this is the pole of the drug bound to protein. So that can't be filtered. But that's always, like anything else, in balance with a small pool of unbound drug. And so different drugs have different affinity for the proteins of the plasma. And one of the papers assigned for the literature review deals with a diuretic again, which has a huge affinity, like 99% is bound to blood protein. So how can that ever be excreted? So the way it happens is this. Let's say this is blood. Here's your cell on the basolateral side. So this cell, investing energy in sodium, potassium, ATPase, and all those transporters, and by the affinity of this transporter, essentially takes up, binds this unbound part of the drug and takes it to the cell. Once it's taken up, another small proportion will be released from, from binding with the protein. So it's clearing this small unbound portion by secretion. That's how kidney facilitates excretion of the drug, which is in this pool, which is bound to protein. Are you with me on this one? Okay. I know that students in the previous years have found that confusing. If something's bound to protein 99%, you can't filter it, so how do you excrete it? And how you screen it if it is for the most part bound to protein? Well, with a high affinity of these transporters and by investing energy for them to very quickly transport anything that's unbound to protein. So that 1%, but that keeps being 1% and 1% and so builds up into a certain amount. So drugs bound to proteins rely on tubule secretion for elimination, which doesn't mean that drugs which are not bound to proteins cannot be secreted. Many are, as a matter of fact, no. But those that are bound to proteins can't be excreted otherwise. So that's almost the only way. And that's when our ABCs, C becomes almost the same as the amount excreted. The equilibrium between bound and unbound form of the drug and the tubule secretion is what I just explained. So although kidney can clear only what's not bound in the protein, it does that all the time. It invests energy, and of course that's very taxing for it, but that's the way it secretes. And it does so by this elaborate setup of basolateral and apical transporters. Now, that's where the drug-drug interactions occur, because there are endogenous substances that drive on those. Now, this has not been made to transport metformin or whatever diuretic we want to excrete. It's been made for endogenous substances. So the secretion of drugs, if a drug has a high affinity for the transporter in case, that can interfere with excretion of endogenous substances, or if there are two drugs, and people very rarely take two, they take 5 or 10, or elderly take 20. So it's mind-boggling how many different substances may be competing for all these different transporters. And to make the things worse, many of these have certain genetic variations which make them faster or slower. So at the end, I have a couple of papers on that. So it's a really mind-boggling how complex that is. And I will give you a couple of examples momentarily, but just to put things in perspective. The reason nowadays people, first of all, the one thing that people often overlook is most cancers, so you have tumors and cancers. So tumors can be sarcomas or cancers. Cancers are of epithelial origin. It's the epithelial cells, and their amazing adaptive capacity. If it goes wrong, they lose their polarity, and when they lose the polarity, they transform into cancerous cell. So most of the cancers are of epithelial origin. Most of the cancers are very able to upregulate many of the transporters, the same ones that are in the kidney, to handle the transport of drugs and substances, or to change their intercellular milieu. And so nowadays, when the cancer, the reason why most people die of cancer are metastases. And many times, if not commonly, the drugs that we give them to treat metastases are actually effective in the beginning until they upregulate these transporters. So the resistance of a cancer cell to chemotherapeutic agent, that's the same thing. They upregulate these transporters and they are very effectively getting rid of it. And so it does not concentrate in the cell. In a sense, it's a parallel process. But because it was designed to bind to some of these transporters, then it interferes where you don't want it to interfere. For example, it also binds to urate. So another problem, why you have so many interactions with the drugs and endogenous substances is because these transporters are relatively promiscuous. If you go from the proximal tubule along the nephron to the more distal parts, all of these transporters become more and more specific, and they would bind one ion or one substance. In the proximal tubule, they have to be promiscuous because they have to support a huge flux, so they can't be too choosy. They have to do a lot, but then that makes for a lot of interactions. For example, probenecid binds to urate transporter, and urate has a very peculiar transport route in the proximal tubule, so I won't talk about the whole thing, but here you can, so this is the lumen of the tubule, this is blood, so urate is reabsorbed through this transporter. So if the probenecid interferes with it, that's useful for the secretion of for the secretion of urate. So less urate will be reabsorbed. So when that is to the therapeutic advantage in gout. So probenecid can be used to treat gout because it will decrease uric acid levels in the blood. But it's contraindicated in the people who form urate stones, because if it interferes with reabsorption of urate, more urate will get into the urine. Urate precipitates into urine very, very easily and forms uric stones. So all these things are relative. It depends on how you design a drug. And it's useful to know all these because you can adjust the design of drug to do these various things depending on what you want to accomplish. All right, so very briefly, you've seen this before. Many drugs are weak acids or weak bases. You know, with pKa's about 5, 4, 5, 6, or so. So these will be in a different of phenobarbital, which is a weak acid, against urine flow. So for the same amount of urine flow, so you have to have filtration and urine flow to excrete something. So let's say urine flow is 2 mL per minute. For the same urine flow, you see the difference in the clearance of phenobarbital. It's almost double, and even bigger difference at higher urine flow rates. So it's much more effectively excreted in alkaline urine. And the opposite is true for amphetamine, which is a weak base. The only thing that's added here is showing the plasma concentration that exists in alkaline urine. So weak base will be excreted less in alkaline urine. So its plasma concentration will be higher and the physiological response will be higher. So this is only to show that this difference in the excretion and the amount ionized that is available for excretion by the kidney may have physiological and clinical significance. All right. So in disease or with aging, glomerular filtration rate decreases, and then we stage that differently. But the point is, our glomerular filtration doesn't get higher, it gets lower with age or disease. And since for the most substances you do need to filter some amount, and often you need to secrete a certain amount, and when in most kidney diseases, once the filtration starts going down, although we don't have at this time good measures of tubular function, we just don't have the good biomarkers, they are usually diminished at the same time. Okay, so if the filtration goes down, the likelihood of secretion going down is high. And it's of course particularly important with aging because here's this diagram that plots filtration rate, age in years. So you see 20 is around 120, 140, and at the age of 40, there's a sort of decline. And once we hit 40, we start losing about 1 mil per minute of glomerular filtration per year. But, the studies that have shown this decline that occurs with age normally and usually doesn't have too many consequences, but has to be taken in account because the excretion of drugs that are predominantly excreted by the kidney obviously will change because the glomerular filtration has changed. So the but is about a third of people in these studies keep the kidney function stable until very late in their 80s or 90s. So it's still unresolved debate whether this decrease of kidney function that typically occurs in most people, in 2/3 of people with age, is that a consequence of comorbidities, because most of kidney disease is high blood pressure and diabetes. So that's why you have kidney disease unfortunately rising. So you have a lot of obesity. Obesity associates with diabetes type 2. About a third of people who have diabetes type 2 will develop diabetic nephropathy, and high blood pressure causes hypertensive nephropathy. So there you have it, about 50-50. So that's the acquired kidney disease. Yes?
So what's causing that lack in filtration? Is it fibrosis of the glomerulus? Is it a lack of transporters? Do we know?
You mean with age or in diseases?
Well, in aging, healthy.
In aging, we don't know. We don't know. It is fibrosis, but what causes fibrosis? Why there is a third of people who never get any fibrosis? Exercise and type of diet and so on. We don't know why in most people. That's why I mentioned that it's sort of an open debate. Is it comorbidities? Is it because so many people have diabetes or hypertension, or is it an intrinsic aging process? So that's for you to find. Yes.
So you said people with diabetes type 2. What about people with diabetes type 1? Do they also?
I'm sorry?
Like people with diabetes type 1 diabetes?
Yeah, either one. Either one may damage the kidney. Not everybody gets diabetic nephropathy, but about a third from diabetes type 2. And diabetes type 1 depends on how they control it. So that's how you prevent kidney disease. You regulate the blood pressure, you regulate the blood glucose the best, and they are looking for other ways. Exercise is probably very good, and the diet that doesn't have too much acid, because acid is one of the things, the endogenous metabolic acid is one of the endogenous substances that we have to secrete. And I have went on and on about how secretion is taxing for the kidney. It needs to use a lot of energy to do that. Okay, so some drugs are excreted by the kidney without being metabolized. With these drugs, renal impairment dramatically increases drug toxicity. Here are the examples. For example, 75 to 100% of these are excreted by the kidney. Metformin is one of the best anti-diabetics. It's terrific in any way. Its only but is the kidney. So if the kidney function is impaired, then there is a certain limit clinically, then you don't give metformin. And they are now working on developing metabolite of metformin that hopefully will not interfere with these same transporters. And for homework, Stephen, where's that? So for homework, I gave you the question regarding metformin and its excretion and kidney function. So you'll find there, and you have a paper to go with it. Digoxin has a very narrow therapeutic range, meaning you have to dose it very carefully, and it's given to elderly to boost their cardiac muscle. So, you know, you're giving it to people who already do not excrete it very well, so that's why people are very, very careful, and so on and so forth. These are some other examples. So, in conclusion, most drugs, except those bound to plasma protein, cross the glomerular filter freely. Many drugs, especially weak acids and bases, are actively secreted into the renal tubule. Therefore, they are excreted more rapidly. Remember, the clearance of creatinine, which is mostly filtered, is about 120 mLs per liter, whereas something that's totally secreted, like PAH, is 700 ml. So much more plasma will be cleared, meaning much faster excretion. Lipid-soluble drugs are passively reabsorbed by diffusion across the tubule, so these drugs are not efficiently excreted in the urine. So that's the business, that's the liver business. So it has to take everything turn it into something that's water-soluble and often charged for the kidney to be able to excrete it. If it is lipid-soluble, kidney can't do much because it just freely diffuses through the membranes. Because of pH partition, weak acids are more rapidly excreted in alkaline urine and vice versa. This is usually important for the toxicity. Several important drugs are removed predominantly by renal excretion and are therefore liable to cause toxicity in elderly patients and patients with renal disease. And I give you for homework, I give you metformin because of classical example of that. And then I have suggested readings, in case you don't have anything better to do. It's fun. It's something that probably in your lifetime will be incorporated in clinical practice. You know, you will be able to get the genotype of these, you know, of the different transporters and to link that to excretion of certain drugs. So the big part of how the drug is affected, metabolized, excreted has to do with these transporters and their genetic variations. Which doesn't mean the lifestyle interventions are still not the best. You know, people often think about personalized medicine only in terms of genetics, but you know, there's so much that we can do before that it's.
Steve, have we done some emails on homework?
Yes.
If it was the homework, it would be like email.
Yes. Yeah. Homework is, in my opinion, is relatively simple. I give you an example, and it's linked with a paper. So its example has to do with metformin and its excretion.
Did you post the homework in that bunch of files?
Yes.
Then the homework will be under today's